Quantitative assessment of mechanical allodynia and central sensitization in endodontic patients by Alelyani et al. It was published in the Journal of Endodontics in 2020. Mechanical allodynia is defined as a reduced mechanical pain threshold to a non-noxious stimulus such as biting, and it is seen clinically as tenderness to biting or percussion. Recent studies demonstrated that teeth diagnosed with symptomatic irreversible pulpitis have significantly lower mechanical pain threshold, and importantly, contralateral teeth in these patients displayed lower mechanical pain threshold as well. Pulpal inflammation produced measurable changes in pain threshold not only in the offending teeth but also in contralateral teeth because of central sensitization. Intense activation of pulpal nociceptors have been shown to evoke changes in wide dynamic range second-order neurons in the trigeminal complex. The process of central sensitization often underlies persistent pain state because it has been shown to be present long after the removal of the primary afferent input, which is the etiology. Therefore, this unexplained pain state is likely present in most patients requiring endodontic treatment due to heightened state of nociception that may involve other sites such as contralateral teeth and muscle of mastication. Hence, the identification of predictors of central sensitization and its quantification allow clinicians to establish a more accurate diagnosis for odontogenic and non-odontogenic pain. Unfortunately, despite the relief of symptoms after endodontic therapy, there are approximately 5% of patients who present with persistent pain despite adequate treatment. In this present cross-sectional study, they investigated whether quantitative difference exists in mechanical allodynia and central sensitization in patients with different pulp and periodicular diagnoses in molar teeth. They further investigated predictors for the development of mechanical allodynia and central sensitization. For the methodology, 70 patients were referred for diagnosis or treatment of molar tooth with suspected endodontic disease, another 10 patients as a control group. They excluded patients who took pain medication in the past 7 days. All patients were seen by endodontic resident who determined and recorded the pulpal and periodicular diagnosis based on the American Association of Endodontics. Normal pulp, which was the control, was defined by the lack of spontaneous pain and positive with no lingering response to the cold sensitivity test, or a positive response to the electric pulp test. The providers further recorded the preoperative pain and intensity level reported by the patient via the 11-point numeric rating scale. Tooth pain duration and demographic data such as gender, age, and ethnicity was also recorded. Mechanical pain withdrawal force in newtons was measured from molar tooth twice from the offending ipsilateral and contralateral teeth using a digital bite force transducer. The measurements were recorded and averaged. For the result, a total number of 80 first and second molar from 80 patients, which was 30 men and 50 women, were included in this study. The mean age was 43 years. There was marked ipsilateral mechanical allodynia for all pulpal diagnoses with the exception of normal pulp and previous endodontic treatment. Figure B shows that previously initiated treatment showed the greatest reduction, which was 64% in the mechanical pain threshold, followed by asymptomatic irreversible pulpitis, which was 60%, then symptomatic irreversible pulpitis, which was 55%, and pulp necrosis, which was 42%. Interestingly, only the diagnosis of symptomatic irreversible pulpitis and previously initiated therapy were associated with the development of contralateral mechanical allodynia or central sensitization. Figure C shows that periapical condition had a significant impact on the bite force threshold. Chronic apical abscess and symptomatic apical periodontitis had the greatest reduction of mechanical pain threshold, followed by acute apical abscess. Furthermore, contralateral mechanical allodynia was only detected in patients with offending teeth diagnosed with symptomatic apical periodontitis and chronic apical abscess. Gender was a significant predictor for mechanical allodynia and central sensitization. Female patients had a reduction of mechanical pain threshold of 48% compared with 23% in men as seen in Figure 2a. This gender difference was also observed in contralateral measurements, with women showing a 19% reduction in the threshold and men show no reduction of the mechanical pain threshold compared with the control group, as seen in Figure 2b. The result of this study shows that symptomatic irreversible pulpitis and previously initiated therapy had a greater allodynia than other groups. These findings suggest that inflammation in either pulpitis or unfinished root canal treatment has a profound effect in the periradicular nociceptors. The study reported that 57% of patients with irreversible pulpitis had sensitivity to percussion tests, where mechanical allodynia was detected in 100% of patients diagnosed with irreversible pulpitis in the current study when using digital force transducer. These findings suggest that teeth diagnosed with symptomatic irreversible pulpitis and symptomatic apical periodontitis must be treated as soon as possible to minimize the time of primary afferent barrage and decrease the development of central sensitization. Also, pulpectomies should be immediately followed by a definitive treatment because the previously initiated therapies included in this study showed and presented with significant central sensitization. The current study female patient had a greater reduction of the mechanical pain threshold across all diagnoses for both ipsilateral and contralateral sides compared with male patient. Despite the relatively limited sample size, these results argue that female at a higher risk for the development of central sensitization and subsequently persistent chronic pain if presented with pain with high intensity for a longer duration. It is known that the activation of pulpal neurons produces central sensitization that persists for a while even after removing of the stimulus, and that preoperative pain greater than 1 week before treatment significantly increased the risk of developing persistent chronic pain over 6 months with a longer recovery period.